Okay, well, why don't we'll give people a few more minutes to join, but we'll also start to dive in. And just a reminder for everyone, if you haven't joined us before for a webinar, this webinar is available in both English and French. To access the French translation, go and click on the globe icon that you see at the bottom of your screen, and then select the French option. You also, if you're choosing the French option, need to click on mute original audio so that you don't hear both the English and the French version. If you want to continue listening in English, you don't have to do anything at all. Great. And as everyone has been doing, as you join, please just introduce yourself and what organization and country you're from in the chat box. Just to introduce ourselves, if this is the first webinar that you are joining, this webinar is part of a series of webinars for the West Africa Regional PrEP Learning Network. Our aim is really to support implementers and policymakers as they develop plans for PrEP rollout, and this is part of the Choice Project. If you would like to learn more about the network and access previous webinar materials and recordings, you can go to the website that you see here on PrEP Watch. You can also, on that site, sign up for our mailing list so that you receive regular emails and all of the invitations to this series of webinars. As we've been going through the series of webinars, we've talked about a number of different topics, including establishing initial plans and guidelines for PrEP. We've gone through topics including demand creation and provider training and community-based delivery models for PrEP delivery. Today, our topic is really going to span these two areas of our framework, thinking about how we can integrate IPV screening and support into PrEP programs, both from a delivery perspective and to support individuals to actually safely and effectively take PrEP, especially in circumstances where they experience intimate partner violence, or more broadly, we know that partner perspectives on PrEP use are a critical factor in people's decisions to take PrEP and continue to take PrEP. So that will all, we'll discuss different approaches to that today. For our agenda, we're really going to start with an introduction to the intersection of PrEP and intimate partner violence. We'll then go through tools and resources for intimate partner violence screening and support. And then we'll hear from colleagues in Eswatini and Kenya about their experiences actually integrating screening and support for IPV into their HIV prevention and PrEP programming. Throughout, we will leave space for question and answer and discussion. If you have a point, also please feel free always to include it into the chat box, and we will bring that into the conversation. We hope this is really discussion based. You can see our panelists here for today. My name is Nirja Babaraju. I'm with the Choice Project. I will be taking us through today's webinar. We will also have Emily from USAID to provide an overview of IPV and PrEP and how we should think about that. We will have Tessa from WITS-RHI take us through some of the tools and resources that have been developed to integrate IPV screening and support into PrEP services. And then we will hear from Bernard and George, colleagues from Kenya and Eswatini, who will take us through their experiences. Just one more reminder, as we know we've had people join us since the beginning, you can access French interpretation on this webinar. If you would like to continue in English, you do not need to do anything differently. If you would like to use the French translation, you can click on the globe icon at the bottom of the screen and select the French option. And once you do that, you do just need to also make sure that you click on mute original audio so you're not hearing both the English and French versions. And with that, we will go ahead and get started. What we wanted to do at the beginning is ask everyone kind of how they integrate IPV screening and support into their programming today. So you'll see a poll pop up on your screen, and it would just help us to understand how different programs are thinking about and currently integrating IPV screening and support into their PrEP services. So we'll let that go for a moment.
We'll keep it up for about 10 more seconds to get your votes in.
Great. Okay. So we should be seeing the results also come up on the screen. I'm not sure if everyone can see these or if just I can see these, but it looks like about half of the programs represented by people on the phone today actually include both IPV screening and support, which is incredible. So please share your experiences here on the call. We'd love to hear from everyone. Some programs, about a quarter of the programs, include IPV screening and referrals to support, and about 15% of people on the phone represent programs that do not include IPV screening or do not include IPV screening or support. 15% of programs include IPV screening and not support, and 15% include neither. So please ask questions. We're hoping that we can all learn from each other today. And with that, I will pass it off to Emily from USAID to walk us through how USAID is thinking about recommendations for IPV in PrEP services.
Thanks so much. Hello, everyone. I am happy to be with you all today. My name is Emily Reitenauer. I am a gender advisor in the Office of HIV AIDS in USAID Washington. Today, I will be speaking about USAID's technical recommendations to address intimate partner violence in the context of PrEP service delivery. These recommendations were developed by the Gender and Sexual Diversity Branch in USAID's Office of HIV AIDS. Next slide, please. As has been well documented, gender inequality and gender-based violence are critical barriers to achieving HIV epidemic control. Globally, 35% of women experience intimate partner violence or non-partner sexual violence in their lifetime. And women who experience intimate partner violence are 1.5 times more likely to acquire HIV. The experience of intimate partner violence has also been found to lower adherence to pre-exposure prophylaxis, or PrEP. In short, violence poses a substantial barrier to the effectiveness of HIV services and can undermine the uptake of and adherence to proven biomedical prevention and treatment options. Next slide, please. Focusing on intimate partner violence and PrEP, There is a growing body of evidence that experiencing intimate partner violence is associated with lower oral PrEP uptake, increased PrEP interruption, and suboptimal adherence to PrEP. Qualitative data has shed light on important contextual factors that clearly underscore how partner dynamics, especially those that feature abusive or controlling behavior, can undermine a woman's ability to effectively use PrEP. Next slide. Gender-based violence, including intimate partner violence, and gender inequality are sometimes seen as standalone issues. But as the evidence has clearly demonstrated, gender-based violence and gender inequality impact HIV prevention interventions and each phase of the HIV clinical cascade. GBV and gender inequality impede the effectiveness and success of our programs and are critical barriers to controlling the HIV epidemic. In response to the impact of gender-based violence and gender inequality on health outcomes and HIV clinical services, including PrEP uptake and adherence, USAID implements key strategic activities throughout HIV prevention and across the clinical cascade to address these barriers, as illustrated in this graphic. Next slide, please. USAID is focused on advancing 4 key gender and GBV programmatic priorities in our HIV programs and services. One of those priorities is integrating GBV case identification and first-line support into specific HIV clinical services. While our approaches are grounded in WHO guidance, one important distinction to know is that for GBV case identification, USAID recommends a hybrid approach of both clinical inquiry and routine inquiry for intimate partner violence in our HIV programs. As a reminder, or for those who are unaware, clinical inquiry is when providers are trained on identifying signs and symptoms of violence and ask about experience of violence when a client presents with those signs or symptoms. Routine inquiry is when everyone who presents for a specific health service, such as PrEP or index testing and partner notification, is asked about experience of violence. This hybrid approach, using both clinical and routine inquiry, is informed by the WHO clinical and policy guidance, which states that routine inquiry may be considered in the context of HIV testing and counseling, as well as when assessing conditions that may be caused or complicated by intimate partner violence, such as HIV. It's important to note that WHO has stated that it recommends that only clinical inquiry be used, but as just described, USAID recommends the hybrid approach, using both clinical and routine inquiry, because we acknowledge that not every USAID PEPFAR site that is required to ask about violence is able to use a clinical inquiry approach. Next slide. It's for that reason that USAID recommends that if clinical inquiry cannot be conducted, routine inquiry for intimate partner violence be implemented within the context of PrEP service delivery. PrEP providers should ask clients about their experience of violence during initiation counseling, not when assessing for PrEP indication or PrEP clinical eligibility. The reason why routine inquiry should be conducted within PrEP service delivery is because, as we previously noted, experience of violence is a significant barrier to PrEP adherence. While clients experiencing violence are still eligible for PrEP, identifying survivors during PrEP initiation counseling allows providers to link survivors to the GBV response services they need to be safe, healthy, and increase their chances of being retained on PrEP. Next slide. Asking clients about experience of violence when enrolling on PrEP is mandated by the most recent version 2.5 of the MER 2.0 Indicator Reference Guide. It's important to note that in order for sites to meet this requirement and ask clients about experience of violence in an appropriate and ethical manner, sites must adhere to the minimum requirements for conducting routine inquiry for intimate partner violence. Next slide. On this slide are 6 minimum requirements that USAID programs must meet to ask about experience of violence, including PrEP programs. These minimum requirements are essential to ensuring clients' safety and well-being, as well as the provision of quality care to survivors of violence. these 6 requirements are as follows. First, providers must offer first-line support using the lives approach developed by WHO. Providers should never ask about experience of violence unless they are able to provide a response and unless they are able to provide first-line support. We strongly recommend that while delivering first-line support, PrEP providers work with clients to identify ways or strategies in which they can take PrEP without their partner's knowledge to keep them safe from violence. Second, a protocol or standard operating procedure for asking about the experience or fear of violence from an intimate partner must be available at every site. Third, sites must use a standard set of questions to ask about violence where providers can document responses. This is particularly important to help limit any provider bias that may influence how questions are asked. Fourth, providers must be trained on how to identify signs and symptoms and/or ask about experience of violence. Fifth, providers should only ask about intimate partner violence or sexual violence in a private setting where confidentiality can be ensured. And finally, sixth, there should be a documented process that allows all providers to offer referrals or linkages to other supportive clinical and non-clinical violence response services. Next slide. To assist country teams and implementing partners in monitoring sites' adherence to these requirements, as well as to assess the implementation of USAID's key gender and GBV technical priorities for HIV programs, USAID's Gender and Sexual Diversity branch developed an HIV GBV site integration tool. If you are interested in seeing a copy of this tool, please reach out to me or my colleague, Amelia Peltz. Our email addresses are on this slide. Next slide, please. As noted, one of the key minimum requirements that PrEP sites must meet in order to ask about experience of violence is ensuring that all staff doing so have been trained on the provision of first-line support using the lives approach. To assist USAID country teams in implementing partners in training their staff to provide first-line support, USAID's Gender and Sexual Diversity branch developed the training providing first-line support for survivors of GBV and HIV settings. This training, which is focused on integrating GBV case identification and first-line support into key USAID HIV programs and services, is adapted from WHO's Caring for Women Subjected to Violence training. USAID's adaptation is a training of trainers delivered virtually. Upon completion of the training, USAID implementing partners are encouraged to cascade the training down to their sub-partners and site-level staff to ensure that all of those working with clients through PrEP service delivery who ask about experience of violence are trained on providing first-line support. Next slide. USAID facilitated 2 rounds of the training to USAID country teams in the second half of last year. The training reached USAID country teams, implementing partners and sub-partners with participants from 30 countries. Overall, 913 individuals completed the training, including participants from 186 implementing partners. Next slide. While most training participants self-identified as working in more than one technical area, 441 participants identified as either delivering or supporting PrEP services. Next slide. At this point, USAID has several next steps following this training on GBV case identification and first-line support to ensure that all sites asking about violence, including PrEP sites, have the knowledge and skills and tools needed to do this important work. USAID is focused on supporting country teams and implementing partners on cascading the first-line support training down to site-level staff, including PrEP counselors. Additionally, USAID is conducting virtual TDYs and working with USAID country teams to conduct remote program monitoring to ensure that sites adhere to the minimum requirements for asking about experience of violence. In the future, USAID will consider facilitating additional trainings for USAID country teams and implementing partners on the first-line support training. And importantly, USAID's Gender and Sexual Diversity branch will continue to work with USAID PrEP technical experts on integrating GBV case identification, first-line support, and referrals into PrEP service delivery. Next slide. Thank you so much for your attention. And for those asking, I will put in the chat box my email address, as well as my colleague Amelia Peltz, team lead for the Gender and Sexual Diversity branch in USAID Washington, her email address. So if you would like to receive a copy of the HIV GBV site integration tool, you can just see those email addresses and send us a message. Thanks so much.
Great, thank you, Emily. Any questions or reflections on what Emily has shared? Please feel free to either add notes to the chat box or just unmute yourself and jump into the conversation.
Emily, I'm just seeing the chat, and it would be great. Oh, great. Thanks for responding to that.
Yes, and for those asking, if you'd like the tool that was referred to, you can email Emily and Amelia, and their email addresses are in the chat box. Any comments, thoughts, reflections about how you've seen this in your own programs, or other questions for Emily or Amelia? Okay, if not, we will move on, but please feel free to come back to this topic and ask questions and share reflections in the as we go along. Great, well, I will pass it on next to Tess from WITS-RHI to take us through some tools and resources that have been developed specifically to consider IPV in PrEP services. Tess, over to you.
Thanks so much, Niraja. Thanks very much to the organizers of this call for inviting me to share some information on some work that we've done through Charisma and just some anecdotal experiences as well. For those that don't know, Charisma was is the USAID and PEPFAR funded project to support the introduction of PrEP or ARV-based prevention technologies. And it was a collaboration between RTI International, WITS-RHI in Johannesburg, South Africa, FHI 360, Sonke Gender Justice, and the University of Washington. And it really formed part of a large collaborative effort among the microbicide product initiatives that were supported by USAID over a 5-year period. Next slide, please. So I think Emily has stolen my thunder because she really has covered really well much of this. But I think the essential piece for all of us to recognize is that PEPFAR asking to have IPV as part of PrEP services and asking about IPV very directly has been a brave step forward from many years ago, where any indication of gender-based violence or intimate partner violence was quite difficult for providers to manage. And so I think this is a brave recognition of us understanding better the link between HIV prevention, relationship dynamics, and gender-based violence, or IPV. And for years, there's been growing evidence, I think, through a lot of the HIV prevention work that's been conducted over the last few decades, that despite there being a number of options that women could potentially use to protect themselves as we've moved closer to oral PrEP and a range of future options, that it's become clear that women are influenced by the dynamics of their relationships with their partners. And so those in violent to controlling relationships find it very challenging to negotiate male condoms and to really implement any other risk reduction approaches. So PrEP, as we all know, offers women that potential to prevent HIV with a level of more control. And following oral PrEP, we all have heard about the monthly dapivirine ring, which is potentially coming through the pipeline in many African countries with the recent EMA opinion, the WHO pre-qualification, and the WHO recommendation more recently, and then followed soon, hopefully, by the injectable long-acting cabotegravir, which takes adherence slightly further away from being a challenge, but still does rely on women to open their door to having options that they can use. And so while all of these options come to delivery, the daily persistent use of PrEP, which is the only option currently available for many women in sub-Saharan Africa, needs support. And gender-based violence, as we know, and other harmful gender norms and inequalities really affect women's adherence. So I think through a lot of the work we've done, we've known that women seek their partner's perspective on PrEP use and may not feel well equipped or to have conversations about it, which frequently raises difficult conversations for partnerships or heterosexual or other partnerships around fidelity and trust. And so partner disapproval of PrEP use is often a driver of discontinuation, especially for women who are in violent relationships or otherwise challenging dynamics. So equipping women to manage these dynamics as part of informed choice and method uptake is essential for safe and effective PrEP use. So it's really critical, where we see on the slide, that asking the questions and having routine inquiry as part of PrEP service delivery is essential. And what PEPFAR recommends is these 3 bullets on the slide: is counselors be trained to ask about violence in a manner that's consistent and easily documented, that they use the LIVES approach, which really, for those not familiar, stands for listen, inquire, validate, enhance safety and support, and providing care for people that do disclose violence. And then the third point, the referrals for clients who really need support when it comes to this. And then I think the important piece where charisma comes in is the request for there to be a very simple standard SOP, job aid, or algorithm that outlines the step that counselors can take if a client discloses experience of violence. Next slide, please. So the standard operating procedure and job aid responds to PEPFAR's call for IPV routine inquiry, identifying women who are experiencing violence. And you can see here that the routine inquiry, the LIVES approach, PrEP counseling for those who disclose violence, as well as staff who experience vicarious trauma, are all part of the toolkit of the job aid. And so if you want to know more about these resources, you can go to the links on the slide, and we're happy to share that, I'm sure, post the call as well. And then really considering adaptations for COVID, which has been essential globally. I think the aspect around vicarious trauma for staff is also trying to be responsive, that it isn't just the participants or the women that are experiencing the trauma. Those who listen to trauma also take on quite a lot of burden, and so there needs to be more done for them to be more effective in their delivery of the work. Next slide, please. So in terms of what Charisma was, it really was an intervention that was developed to address more effective use of ARV-based HIV prevention. And it was implemented with 2 different modalities, initially the vaginal ring, and then more recently in a randomized controlled trial involving oral PrEP, and focused more on the issues around harmful relationship dynamics with male partners and exposure of young women to intimate partner violence. As much as Charisma is very much, all of the work done so far has been very much focused on women, these tools and interventions can be easily adapted to the entire gender spectrum. So it's not just limited to women. It is possible to use this in all PrEP delivery settings with slight modification for the population that we're working with. So when we implemented the Charisma RCT, Basically, it involved a 6-month period of follow-up, and there were a number of steps that were involved in the intervention. First, a brief set of questions called the Healthy Relationship Assessment Tool, which meets or checks one of the minimum requirements within the PEPFAR program to ask a set of questions in a standardized way, and I'll speak more to that just now. And then, based on the responses that women would give to this HEART tool, then be directed to some counseling modules. And these modules really were about healthy and unhealthy relationships, issues around partner communication, discussion of PrEP use with their partners, and then more directly being able to respond, guiding women to be able to respond to intimate partner violence, either through the provision of supportive counseling or onward referrals, and having risk mitigation plans or escape plans for her safety and for her children. Because we understand you can't address violence in isolation, there was also a lot of educational material for partners that could be provided to give insight into what PrEP is about, to make sure that information sharing is easily facilitated for the young woman. And then the support and referrals, because I think when, as Emily mentioned, when you ask the question, you need to be able to respond adequately to it so that people may get services beyond what a PrEP facility might be able to provide and have sustained care thereafter. Next slide, please. So the first step in the charisma intervention was the use of the HEART tool, as I mentioned. And this was really administered at our clinic in both the pilot and the main trial, looking at using lay counselors who asked a set of questions on a tablet or a laptop. And the purpose of this assessment was to assess the client's relationship dynamics. And it initially started off as a 42-item questionnaire, and it's been minimized to about 32 questions, but it can be further compressed based on our more recent assessments to about 22 questions. And so it positions 5 different domains with a number of questions linked to it around traditional values, partner support, whether the partner is abusive or controlling, whether he has any resistance to HIV prevention, and then just generally readiness to use options around HIV prevention. And so this basically allowed you to look at the scores on it. Each of the questions was linked to a numerical value, and then the scores were linked to the modules that followed. So on a higher score on partner abuse and control, this was usually associated with a greater likelihood of reporting controlling behaviors and abusive behaviors or physical violence and sexual violence. And a higher score on partner abuse and control was associated with also with lower partner communication scoring as well, or ability. And so these scores would prompt the counselors or be automatically prompting to a counseling module for the young PrEP user to have. Next slide, please. So these really were the counseling modules responding to intimate partner violence, talking about emotional or physical abuse, helping the young person in really have mechanisms to disclose PrEP use and then seek out partner support, provided that there wasn't a trigger that would lead to increasing her risk of violence, and then using I statements and conflict de-escalation as part of communication. So that she could really open the conversation, which oftentimes is quite hard for a young person to navigate independently. Next slide, please. And given that this is quite a sensitive area to talk with women or men or anybody that's exposed to violence, we also felt it was helpful to have a set of videos that people could watch at the clinic and make sure that they could understand what is the dichotomy, what is the difference between a healthy relationship and an unhealthy relationship. And these were videos that basically were enacted by professional actors, talking and having really a visual to take away with them, and they could watch it on YouTube as well, at their own time at home thereafter, and were provided links if they needed it. And so these videos really were very useful to give to people more than just counseling, but a visual reminder of how they could potentially go about discussing PrEP uptake. Next slide, please. So critically, whenever we think about delivery of interventions, it's important to ensure that in resources such as those in Africa and South Africa, where I live, that they're not extremely excessive in cost. And so part of the informed decision around the staffing for this particular intervention was to integrate the use of lay counselors that would be found in PrEP delivery settings. So we didn't need psychologists or psychiatrists. We needed normal lay counselors who would be engaged with HIV counseling and testing, or voluntary counseling and testing in different settings within the PrEP environment. They needed to, and the counselors on our team were very well skilled by the end of all the training to really adequately implement this. They needed private spaces in the clinic, a referral place as well, which PEPFAR indicates. And we also made sure that there was mentorship from staff with IPV counseling experience. And then ensuring that no vicarious trauma persisted, we had a professional psychologist come in on occasion to debrief with our counselors. So knowing that lay counselors are accessible in most PrEP settings, we didn't target this to higher level staff in clinical settings, because through our anecdotal experience when designing this intervention, young women said they could relate more to lay counselors and they'd be more comfortable talking to lay counselors about violence than they would be talking to a nurse or a clinician who was providing them with care. Because the intervention was in a research clinic and extended, there were periodic refresher trainings and routine observation to make sure that all of the rules were being followed for implementation. Next slide, please. So when we implemented this trial, we conducted a randomized control trial using standard of care around the provision of referrals to people experiencing violence, and then we had the optimized charisma intervention. And the intervention was found to be highly acceptable to women, and it increased women's disclosure of PrEP use to their partners by about 10%. But unfortunately, there was no statistically significant impact on increasing oral PrEP use or experience of IPV detected. There was high levels of disclosure to partners around PrEP, according to the women, and they also appreciated the intervention and the openness to talk about experiences of violence. Now, as much as the intervention didn't increase PrEP adherence, the interesting piece is that this was the first study conducted in Johannesburg at the clinic that I work in Hillbrow, where after 6 months of follow-up of 400 women, we had zero seroconversions. And this is in a high incidence, HIV incidence prevalent setting, where normally you would see in this number of sample participants at least 5 to 6 seroconversions. So what this tells us is that charisma really had some impact, where people were using PrEP around heightened risk potentially in order to have zero seroconversion. So there's certainly something here that needs to be leveraged to ensure that women feel empowered to use PrEP and to use it as they feel around periods of heightened risk. Next slide, please. So for those that are interested in learning more about the Charisma Toolkit and all of the materials, there's quite an extensive amount of material that has been designed by the team and led mainly by FHI 360. And it provides a comprehensive set of tools to support integration of the Charisma intervention with its modules and the HEART tool and the counseling training into PrEP programs. And so there's a guide to implementing the interventions with lessons learned from the pilot testing and the RCT, how to adapt it for different populations. There's a counseling training curriculum, a training facilitators guide with about 2.5 to 4 day training that can be used to equip lay counselors with the skills needed to implement Charisma, including understanding what are the relationship dynamics, IPV, PrEP, and how to provide client-centered counseling that promotes agency. Next slide, please. So the counseling manual, the training curriculum that is there, the counseling curriculum that's there, as well as the HEART tool, is shown. There's a counselor job aid and manuals to guide counselors through the steps of the intervention, including how to administer the heart assessment and then link in the counseling modules, and a huge amount of material to really help facilitate young women discussing PrEP use with their partners. Next slide, please. So here you can see again the heart relationship assessment tool, which can be, for resource limited settings, you can administer this questionnaire on a piece of paper, but if there's resources available, then it can be done on a touchscreen tablet, so women could self-administer or be administered by a counselor. The job aid and the manuals, the educational materials are all there for use and adaptation, and the counseling videos really could be used to open up a conversation with women. At times, asking women about violence when you've just met her or the recipient of PrEP for the first time is extremely challenging. So creating that environment where people feel comfortable, that you're well aware of their experiences and you're well trained to respond to those experiences is really important. And then finally, as we said earlier, if you're going to ask the question, each of the facilities needs to make sure that the referral templates are well collated in terms of what is available in each of your settings to extend this, to link people to mental health support or for additional HIV and contraceptive services. Oftentimes young women who have been victims of violence have little children that also may potentially have been exposed. So what exists for the child? And then for legal services, really explaining to them that you don't have to deal with this forever. There are options, there's legal aid, and linking them to not just psychosocial services, but health and legal services as well. And then really having materials that they can take away with them to remember what PrEP's about, what it offers to them at an individual level. And so I think just the final statement from me would be that it would be really good to have these tools and resources for addressing partner dynamics and IPV and PrEP services be used so that we can see a shift in PrEP adherence for the better and hopefully impact really tangibly the HIV epidemic in each of our settings. Thank you very much.
Thank you, Tess. Any questions or reflections from anyone on the call? Please feel free to add thoughts to the chat or just unmute your line and share thoughts with us. Is there anyone on the line who would like to share their experiences with including this type of support in PrEP counseling?
Niraj, maybe I can just share, just in terms of implementation at our clinic. I think it's important. We found that it was really important to offer this entire package of care to young women because they hadn't had access to it. But aside from the people that walked into our clinic, we found that a lot of young women were taking away a lot of the referral slips. So, just having a little flyer with the legal support, the psychosocial support or the tertiary hospital level kind of access, just having that on hand with numbers or, contact details or an address was really useful because people tend to not know what exists around them and is free. And so it often comes down to the providers to make sure that comprehensive care, it's not isolated just around PrEP delivery, but more holistic care, because that, I guess, integration is the buzzword with everything. And so just integrated referrals and support is really essential in this.
Thank you. Would anyone else like to share any thoughts or reflections or ask any questions? Okay. All right. Well, then we will continue on and hear from our colleagues in Eswatini about their experience integrating IPV into comprehensive programming for key populations.
Okay.
Bernard, can I pass that on to you? Okay, great.
Thank you so much, and thank you to the previous presenter. I'm representing Eswatini, FHI 360, and Bernard Piri. Next slide, please. So in Eswatini, the key populations are continuing to experience violence from mainly from their families, other clients, especially for FSW, intimate partners, and general society. We've seen that mainly in terms of stigma and discrimination. And then there've been reports of physical, emotional, sexual, and economic abuse impeding access to HIV services. So this is mainly exacerbated by the social and legal context where KPs live, including underlying factors of stigma, discrimination, and punitive criminal laws. In particular, the social and legal status of sex workers enables abuse to continue with impunity and without reporting, because we all know sex work is termed illegal, and then it has issues when clients that have been abused are trying to report that abuse. There are also reports that COVID-19 stay-at-home restrictions have contributed to increased cases of intimate partner violence. Next slide, please. So on this slide, this is just an overview of the key populations that experienced intimate partner violence in 2020, and mainly is on MSMs and the FSW. And as we can see, we attend to high numbers of FSW. And looking at the violence that was experienced by two key populations, I think the leading one mainly is emotional, and then followed by both emotional and physical, that is experienced by MSM and female sex workers. And then there is emotional and physical, sexual, financial, physical, emotional, more physical, emotional, and sexual and emotional, mainly on FSW. And yes, we know mainly because of the kind of work that they do and the risk associated with the work. And next slide, please. So on the slide shows the service delivery model. So mainly we operate in the community. We offer community services to the key populations in the country, and mainly through the outreach workers who are also part of the population. And an outreach worker will reach out to a key population, identify key population who's at risk, and it does screening. Those who are at high risk are referred for testing services, and those are screened HIV negative are engaged into HIV prevention programs and mainly PrEP and condoms and lubricants as examples. And then when those have been identified, then they are reached using different modalities. Usually we use targeted outreach testing at the community. We call them mobile services, and also hotspots. We call them targeted venue based testing. And then the community centers. So currently we have 2 community centers in the country. And then when the client is tested positive, then is enrolled into care following the Ministry of Health cascades of initiation of ART if tested positive, sustenance on ART, and also making sure that that client has been fully linked and virally suppressed. And if the client is negative and is accepted PrEP after IPV screening, that client is then enrolled into PrEP and followed up, and also make sure that the client is retained into PrEP care. Next slide, please. And how did we integrate IPV into PrEP services? So during FY20, PEPFAR and MOH Eswatini Ministry recommended IPV integration mainly into HIV self-test, index testing, and PrEP services. So we reviewed the programming needs, including client flow and existing psychosocial services, and we brainstormed on how to integrate into our PSS services. We adapted a training created by EPIC for nurses and counselors into our program, and then we developed an SOP to integrate IPV to all HIV services, and mainly self-testing, indexing, and PrEP as part of our PSS services to ensure safety of all clients that are vulnerable. Next slide, please. So the training, the IPV training, it was done virtually over 3 days, and there were 2 lead facilitators from our HQ, and participants had to complete an online test before the training, and mainly the trainer's responsibilities. It developed role-play sessions and group work to align with the learning objectives. And those are the tools that were used during the training. So on top there is the identifying and responding to violence, HIV programs for healthcare workers. And below is the objective of the training. And it is important to note that IPV services were previously provided by PSS staff with referral from our outreach workers and healthcare workers. And this is the first time that IPV services are being provided by healthcare workers. And it is a new way to think about their role in supporting IPV. Another slide, please. Next slide. Thank you. And then the SOP development, it took multiple develop. Oh, sorry. Please go back. I think we skipped one slide. Thank you. Yes. So on the SOP development, it took multiple different tools and guidance for integration of IPV into index testing and PrEP and also our self-testing. So we reviewed the flow of clients and existing material for all services, mainly focusing on PrEP, self-testing, and index. We evaluated the role of IPV during COVID without existing PSS services on site and potential role after, and then was still to decide on that. Then we ensured tools, that is the referral directory for PSS services, sexual offenses, and domestic violence act available on site for use by the healthcare workers. We provided scripts to ensure healthcare workers have tools for different scenarios, that they speak to the program and not generic approaches. So previously we had PSS services on all the sites, but due to COVID, we restricted the number of people going to mobile services, to only a nurse, and sometimes adding in HTS counselor, and those duties were then shifted to the healthcare workers. Next slide, please. And then here this slide is showing the SOP, the IPV screening SOP that we developed with the assistance of our HQ. So I think we can just, so mainly it was developed from the guidance from PEPFAR requirements, and also with the lives requirements for IPV screening. So we incorporated not just PrEP, but for HIV self-testing and indexing. Next slide, please. So this is an example of the IPV screening tool where there are questions that are asked to rule out IPV for each partner, and it's mainly done by the HTS counselors or the nurses providing services. I don't know if I should go through, but mainly it's on what the counselor asks for each partner. For example, has the partner ever made you feel afraid, emotional abuse, or insulted, threatened, hurt you, or tried to control you, or not letting you out of the house? So these are just examples of the IPV screening tool. Next slide, please. So on the next steps, we in the process of printing out and issuing the developed SOP after integrating IPV screening to multiple program services to formally train staff on SOP, not just the IPV skills, but on how to implement the SOP. We want to review clinical assessment screening tools to integrate IPV to all services that are aligned with our client flow. So this will make it easier for us not to miss any client, and provide training and orienting KP-led organizations on IPV in HIV programs. We'll also need to review and assess the results. Next slide, please. And then on the reflections from our experience, KPs are consistently not need for additional PSS services as access is currently limited. Physical, mental, and emotional, economical IPV is noted as barrier for adherence and general health and well-being. 3 PrEP studies were conducted in 2017 to 2018 in Eswatini And the frequent reason for not wanting to start PrEP and declining PrEP include women feeling that they need partner consent. Gender norms programming is a gap in the country and impacts health services. IPV screening can help play a role in the conversation about IPV and indexing, HIV self-testing, and PrEP, as it is often an undiscussed topic during health services. IPV doesn't have to stop the service uptake of prevention service, for example, but help identify what services will work for the individual. The next slide. Thank you.
Thank you so much. Does anyone have any quick questions for Bernard or any reflections on this approach? Okay, if there are no immediate questions, we'll go on to hear from George from Kenya, and then we will open it back up at the end for further discussion. So George, I will pass it along to you.
Thank you so much. And that was very rich presentation from Eswatini. I'll go directly and share our experiences from the KP programming in Kenya. Next slide, please. Yeah, so in Kenya, the KP programming, which we are implementing through FHI 360, the funding is through Key Population Investment Fund, KPIF, and the focus of the project is to support in terms of strengthening structural interventions and creating an enabling environment at both the national and subnational levels, so that the structural barriers are not an impediment to key populations receiving a comprehensive package of care. And in Kenya, we are supporting 10 implementing partners spread across 7 counties out of the 47 counties in the country. Next slide, please. So I'll focus on how we managed to integrate the intimate partner violence screening into the PrEP programming. How we started this, we rolled out the live training to 76 service providers, and the reasoning behind this was to cascade the same to civil society organizations who we are supporting, so that they could also sensitize their program staffs, paralegals, and also peer educators. And having sensitized that group of people, the peer educators were also to be sensitized on violence services which are available, so that peers at community level would easily reach them, so that the same is cascaded upwards for response. So service providers at both the DIC level and the outreach level screen for intimate partner violence. And as we heard from the previous presenters, just the need for consistency in terms of screening, and also the first line support, and having the right referrals for the same. So healthcare providers are well sensitized on how to inquire about violence and how to respond, and the needed referrals. So any incidents are reported using the violence reporting forms. And also we have gender-based violence GBV registers. So upon visiting a site, you can be able to authenticate the number of violence cases reported by looking at the violence reporting forms which have been filled, and you can also be able to see the action which has been taken for each of the cases, whether for the various forms of violence, including any of the cases where there has been alternative dispute resolution for any of those cases reported. And just to get a picture of how the program is doing, so we shall have a violence reporting summary from where we get reports from the implementing partners, and towards the end I'll be showing part of the data we get from them. Next slide, please. So the training of the service providers basically was to enable them identify and respond to violence in the KP programming, and also educating also the community members just to build the confidence of the key population members to be able to claim, to be able also to stand up for their rights, report, and also challenge violence. So various platforms used to advocate for PrEP use and to discuss how to mitigate the intimate partner violence. So we have PrEP clubs for PrEP users, and we usually encourage the PrEP users because it's a network, it's a social network. We encourage the PrEP users to bring on board those who have interrupted the PrEP treatment to come for the PrEP club days. And also we have the theme days. Theme days is you look at what is it that can move people from the community to come to the DIC for a certain activity. So you may decide to create something like a manicure day. You can have a movie Friday. You can have a party day where they are coming because there is a party, and you use that opportunity to sensitize the group on PrEP use, and also through the same you'll get some people who have interrupted PrEP, have a discussion with them, and ensure that they don't continue interrupting the treatment so long as they're still having ongoing risk of contracting HIV. And also we also use the PrEP days for advocacy to just increase PrEP uptake. And we have several support groups, including support group for partners of sex workers. So we create a specific group, support group for partners of sex workers, so that and this one is mostly done during testing, where you inquire about the partners, and they are invited for their specific PSSGs. Next slide, please. Next slide.
Oh, I think there might just be a delay. Can you see the screening for IPV slide right now?
Okay. Yes. Yes, I can see it from my end. Thank you. So let's start on screening for intimate partner violence. So the screening is
George, you're breaking up a little bit all of a sudden.
This is a form which is filled for any key population member visiting the drop-in center, and so any aspect of violence experienced by the peers is at the initial encounter.
George, I think you might be breaking up a little bit. Is that happening for other people as well?
Yes, but it did start to get better right at the end.
Okay, great. Maybe we can just try it again. George, could you repeat that, please?
You need to change the location.
George, I think you are now on mute, but it might be clear if you try again. Oh, I think he disconnected.
Okay. Maybe let's give him a moment to come back on.
In the meantime, would it be okay for me to put in a plug for folks to fill out our short survey about this webinar series? I'll put it into the chat just while we're waiting for George. I thought I would get that announcement in there.
Great, thank you. Okay, let's give him one more moment. And yes, thank you for everyone on the line. Please do complete. It's a short survey that Casey has just included in the chat. We'd really like your feedback on what we can do to make this webinar series as useful for you as possible. And we'd like to build that based on your feedback. So please do fill in. It's a very short survey. We'd really appreciate your perspectives when you have a moment. And it looks like George is rejoining us. George, can you hear us?
Yes, I can hear you now.
Great, and we can hear you very well. Please go ahead.
Yeah. So apologies for that drop issues with the network. So I had mentioned that screening for intimate partner violence is integrated in the clinic visit form, which is the first encounter for the key population. And in terms of screening for intimate partner violence, this is done both at group level and also on case-by-case basis. And also very key to consider is before initiating PrEP, you really need to look at the safety and storage of drugs for the peer. And we've gone to an extent where violence is suspected just from the issue about storage of the medicines. We link the peers to PrEP champions who in quotes act like a dot facilitator. They keep the medicines for the peer takes the medicines from them because they come from the same social network, and that averts any violence which is likely to happen. So we use the PrEP champions where there are issues to do with the storage of medicines. And also awareness creation, we use PrEP icons or celebrity members, ambassadors, just to advocate for the PrEP use. And also I like the relationship between violence and HIV risk, because you look for that person whom the key population identify with, and you use that person to pass the message. It has worked well having meetings at clubs, bars, and sex dens, just to sensitize the owners and managers about the relationship between violence and HIV risk, and also to obtain their assurance that violence against key populations will not be committed by them or by their customers. So that has also worked well. Next slide, please. Yeah, just sharing some of the tools we use to screen for intimate partner violence. So the first tool just serves as a filter tool to identify clients who might be eligible for PrEP. And it contains a set of 8 questions that assess the behavioral risks of a client. And looking at question 7, that's where you assess whether a client was physically assaulted, including assault by a sexual partner. So intimate partner screening starts from the word go, even before initiating PrEP. And for consistency, the drop-in centers have a set of questions which they ask just to screen for intimate partner violence. The 3 set of questions, just trying to see what the partners have done to the key population just before they are started on PrEP. Next slide. Yes, I'll touch a bit on prevention through crisis response team. So a crisis response committee is usually constituted, which entails law enforcement members. That is mostly from the police and part of our paralegals and outreach workers. And through this, this is to encourage the key populations to report incidents of violence and crises related to PrEP, and also to ensure effective and efficient support from the program at the time of the crisis. So a lot of advocacy is also done with the police and the other power structures during the sensitization meetings. We have meetings with both the junior and the senior police officers, and also other policy makers. And also we provide support to the crisis management team just at the time of a crisis by going to the site of a crisis, whether it's an arrest, we go to the site of the arrest, and also educate key populations on the situation of violence and support offered by the program. So that also entails reviewing the monthly cases of violence, and also telling them out of this number of cases, how many have been settled in terms of clients have been reached, and also the case has been closed. So part of what we need to consider is that we need to factor, because there is an expense, we need to factor violence response costs at a planning stage, so that it is a well-supported activity, because it entails travel, it entails meetings, so we need to factor that. Next slide, please. Yes, so part of some points to note about addressing intimate partner violence. We advocate for key population-led outreaches and services, just to emphasize a bit about protecting key populations. It is not just about meeting targets. We want to just stimulate a collective identity and solidarity among key populations. So we want the key populations to be the natural owners of their programs, so that as they plan an activity, they know what it entails for them in terms of intimate partner violence. So they factor all that. Sometimes, as when we are managing projects, we can be carried by the fact that we have targets to meet. So we want key population-led outreaches and services. We also want to campaign to stop violence against key populations. So a lot of advocacy with the stakeholders to support the campaign to stop violence against key populations. And these advocacies, they include even change in both the country and national laws and policies that criminalize the key populations. Maintaining and sharing lists and reports of aggressors or incidents of violence against key populations. These reports are usually compiled and distributed among the key populations through monthly online chats, as short messages and emails, so that they can know where to avoid potentially dangerous individuals or some dangerous sites. And also, we just ensure that the programs to support, they have created safe spaces, just drop-in centers that allow key populations to come together and discuss common issues. Part of them is the intimate partner violence. And also setting up crisis support lines, so which are toll-free, so that they can reach in times of crisis. And also ensuring that we provide both health and legal services to key populations who experience violence, including having pro bono lawyers. Next slide, please. Yes, so
Sorry, George, go ahead.
We may have lost George again.
I
George,
think he's on mute.
you can hear me now?
Yes, we
we can
can.
hear you now.
So thank you. So part of the lessons we've learned from the key population program in Kenya is that persistent violence calls for stoppage of PrEP, because our goal is no harm to the key population. Increase in violence also reduces retention in PrEP. So we really need to put our resources and our efforts to address violence cases. We need to address storage of PrEP drugs. That needs to be taken very seriously, and where the storage might cause intimate partner violence, that also needs to be addressed. Also important to track intimate partner violence, and also to differentiate it from just the general gender-based violence where possible. So we have a lot of data on gender-based violence, and very little data specifically on intimate partner violence. And as I mentioned, we need to factor violence response costs at planning stage. Next slide, please. So this is a snap preview of the data we capture, and just some data for decision making, looking at the GBV cases reported, and also looking at those cases reported, how many of them are actually able to access some clinical services. So we can see there was a bit of a decline from November to December. And looking at the second graph, we can see where there is low percentage of clients who receive clinical services is where there is no integration of services. So integration of services is key for GENT GBV to be on the higher side. So you need integrated services so that clients, you can be able to account for the services they get. We do referrals, but it works well when services are integrated. Next slide. Yes, so from the looking at the intimate partner violence services, Out of that, we are able to interrogate the clients who come for our services. And out of that, we managed to enroll more clients into our KP program. So out of looking at the intimate partner violence and the GBV cases, managed to enroll 20 more KP members and managed to test more clients. Also managed to identify non-positives, some clients out of those GBV activities. They are put on post-exposure prophylaxis, others on emergency contraceptives, others are referred to rescue centers, and others are also referred for just general counseling, some enrolled on PrEP, and others put on STI treatment. So this is the output we get just from the GBV activities or screening for the intimate partner violence. Thank you.
Thank you, George. Would anyone, any final comments or reflections on any of these presentations? I see one in the chat from Michelle asking, George, if you have any data on how many people actually take up referrals and go to the referred services.
Yes, that is part of what is reported. We report the number of clients who are referred, and because this is a cohort of people who still the ones who come back to us, or the ones who go to, we have link facilities. The ones who go to the link facilities, which are key population friendly, we are able to get that feedback of the referrals, how many reached and how many accessed the services. So we have that data.
Great. Well, I know we only have a few moments left. So thank you to all of our presenters and participants. Just a reminder to please, if you can, fill out this short survey that Casey has included in the chat box. We'd really value your feedback. We want to make sure these webinars are actually useful for you. So please, please share your thoughts in the survey. Our next session, it will be on March 25th. We will be joining up with a global PrEP learning network to discuss considerations for the provision of event-driven PrEP. This was the topic that was rated highest in our survey from the last session in terms of a topic that is of interest to people. So Casey has just put in the chat box a link where you can sign up to further emails and sign up also for that session. So the next session will be on March 25th on event-driven PrEP. And then following that session, we are really eager to get your feedback in the survey. And so any additional sessions will be defined based on the feedback that we get back from all of you from the survey. So please stay tuned for that. And just a reminder that you will be able to, shortly after the webinar, find the materials and the recording from the conversation on the PrEP Watch site that is noted here. So you can just look for the West Africa Regional PrEP Learning Network and you'll be able to find the slides from today's presentation. They will also be emailed out to you in the coming weeks. Thank you all very much for joining, and please feel free to reach out to us with any questions, further questions, or any thoughts for how we can make this series of webinars most helpful for you. Thank you very much.
Thank you. Bye.
Bye, everybody.
Thank you.